Good afternoon. This is Dr. John Bennett trying to get on the screen here. Okay. From Miami Beach, Florida, the headquarters of Neurosurgical TV. As you see, we're getting fancy with the backgrounds and everything. We have the honor today of having Ulrich Sidney, a Cameroonian medical student, that's going to be discussing ethmoid bones and the neuroanatomy of ethmoid bones. Let us go around the panel first and introduce everyone. Let's start with Young Hong. How are you today, Young Hong? Could you please introduce yourself?
Good.
Okay.
I'm from China, and my center is mainly in neurotrauma and hemorrhage, and so I do some cystectomy surgery. Very nice to meet you.
Very good. Young Hong runs a cysternostomy group in China. Stuart. Stuart, can you introduce yourself, please?
Hello, my name is Stuart Portilla from Ecuador. I'm a young neurosurgeon. It's a great pleasure to be here.
Okay, welcome, Stuart. He's an active member of the Spanish community. Dylan?
Hey everyone, I'm Dylan from Cameroon, 70 medical student. Nice to meet you all.
Very good, very good. Okay, Ulrich, it's all yours and welcome.
Thank you very much, John. Thanks to everyone who's attending today. So those who are on the application Zoom and those who are on YouTube and hopefully Facebook for the next time. Our group is AFAN, that's the Association of Future African Neurosurgeons. So we are basically medical students. Some of us are general practitioners and some are residents. And we're trying to increase not only the quantity and the quality of African neurosurgeons. As you know, there are not that many in the sub-Saharan African region. And we'd like to use this platform to get in touch with some of the best, like you guys here, and exchange, learn, get to network. So thanks, John, for the opportunity. In sessions, we decided we're going to start with neuroanatomy and skull anatomy for us who aspire to be future neurosurgeons. So our session today will be about the ethmoid bone. So let me screen share so that we can get this going. Okay.
Okay. There you go.
Okay.
Very good.
So I'll present myself. I'm Ulrich Sidney, final year medical student from Cameroon, and I'm a future research associate at Harvard University in the program for global surgery and social change. And today we'll be talking about the ethmoid bone. So the ethmoid bone is one of the numerous bones we find at the level of the skull, because we know the skull has a skull vault and a skull base. So the ethmoid bone forms the skull base, and it's a very important bone for the neurosurgeon. So we're going to be talking about the anatomy, but as we're going to talk equally about the operative anatomy. So the ethmoid actually comes from the Greek word ethmos, which is a sieve. Sieve because of the cribriform plate, because of the cribriform plate, which looks like a sieve. The roof of the nasal cavity is actually formed by the ethmoid, and it actually participates in the medial wall of the orbit. We're going to see further that the ethmoid articulates with a lot of bones, up to 15 in total. And so it's really complex anatomy around this area. We need to understand these rapports, these different interactions between the different bones to better understand the surgical anatomy and decide for which procedures we're going to be adopting and the approaches as well. The ethmoid bone, so it forms the anterior and middle thirds of the medial part of the anterior cranial fossa. So the anterior The cranial fossae are three of them: anterior, middle, and posterior. And the anterior and middle are separated by the sphenoid ridge, as we all know, and the middle and posterior are separated by the preacher's part of the preacher's part of the temporal bone. So the ethmoid is a very important part of the anterior cranial fossa, so very important for skull-base surgery, so skull-base anatomy. It equally constitutes part of the nasal septum which separates the nasal fossa into two and participates into to constitute the lateral nasal wall. It is made up of three parts, which we can have here. We have the cribriform plate, which gave it its name, the name for sieve, ethmos. This is the cribriform plate. And we equally have the perpendicular plate. This is the perpendicular plate, yeah, in pink, reddish pink. And we have the ethmoid labyrinths, which are these huge masses, which are lateral here. Obviously, there are other important aspects, anatomical aspects, which we'll be defining and describing on these three main parts of the ethmoid bone. So we like to start with the embryology because the embryology gives us a better understanding of some of the anatomy, the variations, as well as the pathology for structures. So embryologically, the ethmoid is part of the chondrocranium. Chondrocranium because chondros for cartilaginous, cranium for the skull. So it's part of the chondrocranium. On its upper surface, we have the olfactory bulbs. This is very important from the embryology because we will understand later on why. The first pair of cranial nerves, which is the olfactive nerves, will be in a very close rapport with the ethmoid bone. In the primitive skull, we can find the olfactory capsule, out of which the cartilaginous ethmoid bone will evolve, and there will be this space which separates it and helps contain the forebrain. The cribriform plate, which we showed earlier, which has this sieve-like aspect, is formed at 4 months, and up till then, a gap separates the lateral mass from the septal or trabecular plate. There are numerous articulations we can describe for the ethmoid bone. Like we said earlier, the ethmoid bone is a very important bone for the skull base, especially the anterior cranial fossa. So the ethmoid bone, first of all, is single bone, so it's unpaired, it's medial, and it gets into contact with a number of bones, a number of 15. We can separate them into the paired bones and unpaired bones. Others will separate them into cranial bones and the facial bones. So whichever, it's good to know the different divisions. For the paired bones, what we can describe are the nasal bones. The nasal bones, which form a part of the architecture, the skeletal architecture of the nose. The maxillae, which are which is the upper part of the buccal cavity, the upper bony part of the buccal cavity. The lacrimal bones, which are with the ethmoid bones, will form the lateral part, the medial part of the orbit. The palatine bone, which forms the roof of the oral cavity. So, and then finally we have the inferior concave. Inferior concave because the ethmoid bone actually has the other two concave, which are the superior and medial middle concave. Then for the unpaired bones, we can describe the frontal bone, the vomer, which is more interior, and finally the sphenoid bone, which was described last week by a senior, the Dr. Neurosurgeons, who presented the sphenoid bone, very important for skull-base anatomy as well. So talking about the articulations, we can better visualize this in these different structures. So what we have here, well, we have, this is the ethmoid bone, which is blue. It's blue all over, and we can see it's transparent, so we can see some structures which we'll be describing later on. These are the ethmoid cells. And as well, we can see that here we have a view of the orbits, and clearly we can see that the ethmoid bone is medial, so it participates to the medial boundaries of both orbits. And with this situation, it will be in contact with the lacrimal bone in front of it, or be in contact as well with the maxilla. So we can see here, we have part of the maxilla here. We have the lacrimal bone here. And we have the sphenoid here. We have the sphenoid bone here. And obviously, this is our ethmoid bone. We took out the frontal bone which will come and form the roof of the orbit, and then we'll get into contact with the ethmoid. And below and behind, we have the vomer that comes and articulates with the sphenoid bone, as well as the palatine bone. So we're talking about the ethmoid bone, and we described that the ethmoid bone has 3 parts. Some will say 4, but actually the last parts we described are actually 2 of them. That's the lateral processes that we'll be describing for the ethmoid. So we start with the cribriform plate. We said earlier the cribriform plate, which is sieve-like, and it's represented here in blue here, the cribriform plate. And we understand why cribriform, because it has a lot of punctures, a lot of holes there, giving it the aspect of a sieve. Why these punctures? Well, because the nasal fossae have the nerves for the olfactive nerve. There are the different roots for the olfactive nerves that are at the superior part of the nasal fossae. So these nerve roots will be passing through these punctures in the cribriform plate to go on and form the olfactive nerve and olfactive bulb. So it is pierced by numerous olfactive nerve fibers, which give it a sieve-like structure. And projecting superior to this cribriform plate, we have this structure here, which we call the crista galli. Now, to the crista galli, we can describe numerous structures. We can describe laterally crista ele, and pointing upwards and superior here. We can have a crista galli. Now, the crista ele will go ahead and articulate with the frontal bone, and it will leave a space, which we described a couple of weeks back when we were talking about the frontal bone. We spoke about the foramen cecum. So the foramen cecum was this space that was defined by the ale of the crista galli articulating with the frontal bone, the orbital part of the frontal bone. And this foramen cecum will be a means for passage of emissary veins which permit the communication between the external, so the exocranium and endocranium in terms of vascularization. As well, the crista galli is this structure that points upwards because it provides insertion for a dural fold, and the dural fold here is called the falx cerebri. The falx cerebri is this dural fold which is medial and which separates both aspects of the telencephalon, that's both hemispheres, and so it permits the insertion of the dura, that's the falx cerebri. And when we look inferiorly, we're going to describe another structure which projects inferiorly. That's the perpendicular plate, but that's another description. So we come now to a perpendicular plate. Now, the perpendicular plate that we find here is in blue. Perpendicular plate. It looks sort of medial, but usually what we find is that it's not properly medial, so it's not really mid-sagittal. It has a tendency to deviate away slightly from the mid-sagittal line. This structure, which we call the perpendicular plate, is vertical, and it constitutes the superior 2/3 of the nasal septum. So it's very important to understand this for endonasal approaches, actually. So the perpendicular plate, which we can see here as well, perpendicular plate, and here, this is a lateral view, and we can equally see the superior concave and the middle concave. Now, two lateral masses we described are the ethmoidal labyrinths. Now, the ethmoidal labyrinths are large masses located on either side of the perpendicular plate. They contain ethmoidal air cells. Now, these ethmoidal air cells are, they in vivo, they are separated actually by surrounding bones. So the different bones we find around articulating with the ethmoid are actually the ones who come and divide these different air cells. So they help to have these air cells. And then the other thing is the ethmoidal labyrinths don't have a roof per se. When we take out the ethmoidal labyrinth, the ethmoidal bone, the ethmoidal labyrinth has no roof. So it has a roof which actually belongs to the frontal bone, which we'll be describing and showing in the next slide. There are two sheets of bone which form each labyrinth. There's an orbital plate, like the name suggests, in contact with the orbit, which is a lateral sheet of bone which also forms the medial wall of the orbit, and a medial sheet which forms the upper lateral wall of the nasal cavity, from which the superior and middle concha extend into the nasal cavity. So the ethmoidal labyrinths, we said within them we find the ethmoidal air cells. And these ethmoidal air cells are formed by the different components we already had, the different components from the various bones that articulate with the ethmoid. Whereas the ethmoid sinuses will be constituted by the different parts of the ethmoid. That's the crista galli, the cribriform plate, the perpendicular plate, and both ethmoidal labyrinths. So the ethmoidal air cells are divided by basal lamella of the middle turbinate into anterior and posterior divisions. This, we have to say here that this division is surgical. So in terms of surgery, we speak about anterior and posterior divisions for the ethmoidal air cells. But in terms of anatomy, we have anterior, middle, and posterior. So the surgical division, actually anterior is the anatomical anterior and the anatomical middle, whereas the posterior remains the posterior. The anterior and middle air cells will drain in the middle concha, whereas the posterior air cells would drain into the superior concha. So we have a better view of our ethmoidal labyrinths here. We can remember a little bit here. We have a crista galli here. We have lateral processes, ethmoid labyrinths, and in transparency, we can see the ethmoid air cells. And we can see here that we have the superior and the middle concha. We have a perpendicular plate here, which is vertical and medial. Here, cribriform plate. And the roof of the ethmoid labyrinth, like we said, is actually free in terms of the ethmoid bone. It's constituted by a part of the frontal bone. So this part is called fovea ethmoidalis. So the fovea ethmoidalis attaches medially to the thinner lateral lamella of the cribriform plate, completing the roof of the ethmoid air cells. In terms of vascular anatomy, here there are two vessels, the anterior and the posterior ethmoidal arteries, which are branches of the ophthalmic artery. The posterior ethmoidal artery is actually a lot smaller than the anterior ethmoidal artery. So that for the description, posterior ethmoidal artery arises from the proximal first segment of the ophthalmic artery, whereas the anterior ethmoidal arteries will arise from the distal intraorbital third segment of the ophthalmic artery. And they penetrate the lamina papyracea, which is this really thin sheet on the lateral parts of the ethmoid, into the roof of the ethmoid sinuses, which we described already. We said the ethmoid sinuses are comprised of 5 parts, essentially. That's the cribriform plate, the ethmoid lateral masses, the perpendicular plate, where it gives off its dorsal nasal artery, and through the cribriform plate flows to the crista galli, to the intracranial opening of the anterior ethmoidal canal, and to form the anterior falx artery. And like you guessed, the anterior falx artery is an artery that we'll find in the falx cerebri. Both posterior and anterior ethmoidal arteries have meningeal branches, so they give meningeal branches. In terms of radioanatomy, we have a classification which helps us calculate the depth of the olfactory fossa, which is very important for the olfactory bulb. And this depth is calculated and given a classification, which is a curious classification. The most frequent is type 1, and the least frequent is type 3. Type 3 is very prone to erosion, and so if it's prone to erosion, even to trauma, and there's a risk for spontaneous CSF leaks, for example, and encephalomeniнгocele. We have here two of the classifications, the type 1 and then the type 2. So in this, let me get my cursor. Here we have a crystal galley here. So this is our orbit, and like we described, on the medial part of the orbit, we have a participation for the by the ethmoid bone. And here what we have are air cells. Here is the perpendicular plate. As we can see, it's not really mid-sagittal. This is maxillary sinus here as well. So same description. And well, we know all this anatomy now. We need to be able to apply this anatomy to surgery for operative purposes. So one very important aspect is anterior skull-based meningioma. There are three types of anterior skull-based meningioma which we can describe. The first one is the one that will interest us the most. That's the olfactory groove meningioma. We equally have meningioma of the planum sphenoidale and meningioma of the tuberculum cellae. Olfactory groove meningioma have as origin the meninges of the cribriform plate, and equally the sutures for the frontosphenoidal suture, the sphenoethmoidal suture, and the frontoethmoidal sutures. We have to say here that the clinical presentation for anterior skull-based meningioma is not very rich. There's not a lot we can have, especially for olfactory groove meningioma and planum sphenoidale meningioma. The reason here is that the structures around this area can easily be compressed without manifesting clinical signs. So usually when anterior skull-based meningioma are discovered, it's well after the initial growth. And another thing is they grow really slowly. So for them to double their size, it has been estimated that it can take about 5 to 6 years for them to double their size. So usually they're found with really big volumes. And we will understand with different operative possibilities how we will choose classically to operate on this olfactory growth meningioma, planum sphenoidale meningioma as well. So presentations what can we have? We might have behavioral changes, personality changes, headaches. Some really rarely, but somewhat peculiar is the Foster-Kennedy syndrome, where we have unilateral optic atrophy, unilateral anosmia, unilateral central scotoma, and contralateral papilledema. For the tuberculum cellae, it's a little bit different from the other two, because the tuberculum cellae, given its proximity to the chiasma on one part and then the cellae on the other part, that's I mean by that the pituitary. So the signs are seen a little earlier than we'll see. We should equally say here that the anterior skull-based meningioma constitute about 10% of all meningioma. And remember that meningioma are the most frequent extra-axial tumors we find in the brain, usually benign, but some of them can manifest malignant characteristics. So I took this quote from Professor Mohamed El-Fiki, who is an Egyptian neurosurgeon, he has been, he's a great neurosurgeon. He has been past president of the Egyptian Neurosurgical Society and published a lot. So he says this about anterior skull-base meningioma, that vascularity may be ameliorated if the ethmoidal arteries are controlled intra or extracranial in the orbit or in the ethmoidal roof through microsurgical or endoscopic approaches or endovascular. Like we all know, meningioma have a particularity in the fact that they are usually very vascularized. CT scan usually isodense, and then in terms of MRI, they pick up a lot of gadolinium, and between 50 and 72% of the cases, we will find that they manifest after the gadolinium has picked up, they will manifest the dural tail. Screen share. Young, you're screen sharing. Oh, sorry, guys.
Sorry.
It's okay. I'll trade it out. I'm getting whoever's off. So it's all yours now. It's all yours.
Okay.
Sorry.
No worries.
No problem.
Okay.
Yeah, thanks. So, given that meningioma are heavily richly vascularized, it's very important to be able to control this vascularization, and this can determine the success of surgery on anterior skull-base meningioma. The great majority of anterior skull-base meningioma are vascularized by the anterior and posterior ethmoidal arteries. So, like we said earlier, the anterior and posterior ethmoidal arteries are actually branches of the ophthalmic artery. So, one possibility, obviously, is embolization. But the risk of the embolization in this case is that we can have a iatrogenic embolization of the ophthalmic artery, in which case we will have a visual deficit. So that's one of the risks. And so we need to be careful. Another option besides embolization is clipping. So anterior skull-base meningiomas are supplied by ethmoidal arteries 10% of the time. Operating a less vascular field may be achieved if we control the feeding anterior and posterior ethmoidal arteries pre-operatively or early intraoperatively. So when we have to operate on anterior skull-base meningiomas, specifically olfactory groove meningioma, we have two options. We have microscope on one side and endoscope on the other side, endonasal endoscopy. Well, the discussion today is not which one to do in which case, but we already know the general principles. With endoscopy, we can access a lesion with less trauma. It's minimally invasive compared to a microscope. The difficulty here is that we have 2D view, and then other difficulty is if we have to control bleeding, hemostasis, it's usually more difficult with an endoscope than with a microscope. Then there's also the learning curve. And if the tumor is really voluminous, then it's better, we're better off choosing microscopy. However, if we have to do endonasal endoscopy for this surgery, we would choose preferably a 30-degree rigid endoscope. And here when we try to do control of the ethmoidal arteries, we can use a few tips, a few caveats. So the artery will be parallel to the ethmoid sinus roof as it curves along the cribriform plate, posterior lateral to anterior medial at an angle of 60 degrees to the lamina papyracea. And so the anterior ethmoidal artery will be posterior to the anterior face of the bulla ethmoidale. So the bulla ethmoidale is a part of the lateral bodies of the ethmoid, and it's called bulla ethmoidale because it contains air cells. So it's usually one of the biggest cells at that region. The posterior ethmoidal artery at the junction of the roof of the set of the sphenoid and the posterior ethmoid sinus. That's where it can be found. Other clinical relevance is for in cases of ethmoid fracture. So the ethmoid bone can be fractured in cases of facial trauma, for example, most commonly hitting the dashboard in case of a collision or fall from height. Some signs and symptoms of fracture are related to the anatomy of the ethmoid bone. So like we said already, we know that the ethmoid bone has a cribriform plate in which we can find the branches for the olfactory nerve. So for the olfactory nerve, if there's a lesion of the olfactory nerve, we're going to have anosmia. So another problem is if we have lesions of the labyrinth, this may allow communication between the nasal cavity and the orbit, in which case the air from the nasal cavity will go to the orbit and we have a case of orbital emphysema. Another case is CSF rhinorrhoea. CSF rhinorrhoea can be traumatic or it can be in spontaneous. Spontaneous, for example, when we have a very thin lamina papilla, a very thin olfactory groove depth. So a fracture of the cribriform plate may allow communication between the nasal cavity on the one part and then the central nervous system, in which case we'll have CSF leak, and this CSF leak will be causing the communication between the brain on the one part, which is inside, and the exterior. So there's a risk of meningitis. In this case, most of these cases are handled conservatively, so there's no need to operate in most cases. Here we have a cysternography, and we can clearly visualize that CSF is in the nasal cavity. So these were our references, and thanks for listening. If there are any questions, please.
Very good. Thank you very much. You're a little advanced for a medical student. That's a great presentation. Thank you very much. Before we open up the questions, let's quickly introduce two neurosurgeons that came. Marco, greetings, Marco. Hello.
Hi, guys. How are you?
Hello, Marco.
Hello,
Hi.
Marco.
Yeah, Marco's a neurosurgeon from Italy.
Yeah, we've met a couple of times.
Right.
Yeah.
Okay.
Hi, Eric.
Also, we'd like to welcome Naru. Hello, Naru.
Hello. Hello, everybody. Hello, John. Hello, Ulrich.
Hello.
Okay, you got four neurosurgeons here, Ulrich, to give you a little feedback. Great, that's great. And Young-Hong, anyone can comment on the importance of this type of anatomy, why a neurosurgeon has to know it cold. Maybe you guys can comment on that.
Maybe like that. Okay, it is clear now. Yes.
You want to start off, Marco, the importance of knowing, well, yeah, you missed the presentation, but he basically gave a very comprehensive review of the ethmoid area in neuroanatomy. And I imagine it's important really to know that. It seems central, right, Marco?
Yeah, that's right. In particular, I take advantage to remember the importance of the ethmoidal arteries, in particular when they are the only one to vascularize retrogradely the retina, because we need to remember that in some cases the internal carotid artery is stenotic, and so the blood flow for the retina is guaranteed by anastomosis between the facial artery and the lacrimal artery, then go to the ethmoidal artery, and so to the retina. So it's very important in the pre-operatively planning to perform an angiography and to see if there is some prevalence of flow throughout the ethmoidal artery, because on the contrary, there is the risk to sacrifice the ethmoidal artery during the operation and make the patients blind.
Okay. Thank you very much. Thanks.
Thanks, Marco. Any other comments? Young Hung? You've been around the ethmoid area very much, Young Hung?
I'm Yun Hong, and thank you for your good presentation. And ethmoid ball is very important for arterioscopic surgery. So we especially endoscopic surgery, such as CSF leak and meningioma. So, thank you.
Well, you know, the ENT, I didn't know ENT surgery had so much in common with neurosurgery. And that's one area where ENT also does surgery, correct?
Yeah, absolutely.
In
Absolutely.
the ethmoid area?
Yes, yes, yes.
Because I put a notice out to a prominent ENT surgeon in India saying that, hey, we have this talk now by a Cameroonian student about the ethmoid area and its relevance to the ENT neurosurgeons also. So, Naru, any comments or anything to say to Ulrich? I know you missed most of it, but he talked about he gave a very comprehensive talk about the ethmoid area.
I was a little late. I'm sorry. I just finished to operate and come back quickly to home, so I'm sorry to be a little late. I see the clinical relevance you do about this special bone ethmoid, and it is good presentation, and I encourage you to do more and more. And I have just one comment about CSF leak. And you have to know that in our area, it is not immediately we going to perform endoscopy treatment. Sometimes you have done shunt lumbar to treat CSF leak. If we done it maybe for 5 days, if we don't have rhinorrhea, we can conclude that it is okay. We don't have CSF leak more, and you can. But if after shunt, lumbar shunt external, sometimes we can done just punction, lumbar punction to release maybe 40 cc of LCF. We can do it 1 day and 2 days. And if it's not okay, we're going to shunt, to lumbar shunt external to 1 week, and to see if we don't have any rhinorrhea, we can remove that and let patient. If inside this management, patient come back maybe 3 weeks after or 1 month after, and continue to with rhinorrhea, then we can go to perform endoscopic treatment or another neurosurgical treatment, as you know. So that's just my comment about CSF leak, post-traumatic or spontaneous, because not all CSF leak who is post-traumatic. Sometimes you can have congenital malformation about ethmoid bone or sphenoid bone. We can have CSF leak. So that is my comment, and thank you for your presentation, Ulrich.
Very good.
Thank you very much.
Thank you, Nuru. Stuart, do you have any comments or questions about the ethmoid area for Ulrich?
Dr. Ulrich, thank you. Really good and clear explanation, good presentation. The importance of this part of the base of crane is very important, relevant for the endoscopic approach. And in case of trauma, it's very important to know the anatomical points to don't damage more the very noble structures like olfactory nerves, like the vascularity. A good explanation about the branch and the border bone vascularity, and relations with other important structures like carotid arteries and venous branch. Thank you. This is really clear explanation.
Thank you very much.
Thank you. Thank you. Okay, any other comments or questions? Okay. Okay, very good. This wraps up the presentation for this week. One thing I'd like to add a little something different because I'm curious about Cameroon, exactly where it's at. And I asked Ulrich if he'd like to give us a brief tour, and we could possibly do the same with the other neurosurgeons real quick, just to give us an idea. Go ahead, Ulrich, take it over.
Okay, thanks, John. So Cameroon, for those who love football or soccer for you, John, you must have heard about Samuel Eto'o or
Yes.
Roger Miller. So, and if you like basketball, then you have heard about Joel Embiid.
Of course.
I hope you, yeah. So Cameroon is the country of those amazing guys. Cameroon is a country in West Central Africa. And
can you show us a map? Can you show us a map? Screen share a map, or you want me to? I'll do it.
Yeah, it's better if you do, because my connection is not great.
Yeah, okay. Yeah, I guess you're not ready for this. This is kind of an impromptu thing. Maps, Google. Okay, let me just set it up here.
Why you're setting it up? So Cameroon is it's called Africa in miniature. So because there are so many cultures, we have about 250 different ethnical groups and that many languages as well. That's for local languages. But in terms of
good players in Cameroon, good soccer players.
Yeah, absolutely. And
it's very central to Africa, huh?
Yeah. Oh yeah, there you go. Thanks, John. So you can see Cameroon here. It's next to Nigeria on the western part. We have Chad, Central African Republic, Equatorial Guinea, Gabon. The capital is Yaoundé, so it's somewhat in the southward, and Douala is the economic capital. So you will find a little bit of everything in Cameroon. You'll find some deserts, you'll find some forests, you can find, in terms of fauna, you can find giraffes, you can find lions. So I mean, if you get a chance to come to Cameroon, you should come to Cameroon. You will love the experience. Yeah, you will love the experience. We have two official languages, that's French and English. So not everyone speaks French and English. So you'll find some people that can speak both and others that just speak either French or either English.
Very good, very good. It's very interesting. I hope we all can get there.
And you guys,
we look forward to you getting to Boston also. Can we briefly go over it? Young Hong, could you show us where you're from? And could you please show us get an idea of where everyone's from here? Just a quick little tour of the city you're in China.
Okay.
Because we have a varied group today from China, Ecuador, Italy,
China,
Morocco.
City.
You want me to do it? I can do it if you want.
Okay.
You want me to do it? I can do it. I should. Okay, I'll do it. Here you go. I got it. Okay, there we go. Okay, where are you at?
This one, Taiwan City.
Okay, I gotta get the spelling there.
This part.
Hold on. Yeah, let me get back there. I'm getting confused here.
This, Shaanxi.
Hold on. I'm wrong. I'm getting confused here. Stop share. Okay, I'm sorry. Let me screen share again. Okay. Is it south?
This part.
Near Hong Kong?
Middle.
The middle here, Hunan?
Yeah. Shaanxi. Up. Yeah.
Here?
No.
The Zhenghu.
Shaanxi.
Chinese very great.
Up.
It's very difficult.
Up.
Okay.
China is very big.
Up.
Yeah. Yeah,
This
Beijing?
Taiyuan. This part.
Higher
Taiyuan.
than that. Beijing? North of Beijing?
This. Yes, North Beijing. Yeah.
Wow, north of Beijing.
Yeah.
Wow.
Yeah.
Very far north?
Mm-hmm. This stop. This part.
Right here, Xinghang?
Taiyuan City.
Oh, Taiyuan.
Taiyuan. Taiyuan.
Oh, okay, there, right?
Here. No. Let me show you.
Okay.
Let me show you.
Okay, I'll stop share. I'll let you go.
Stop. At the
Oh, okay.
this part. This.
Oh, okay.
Yes.
Yeah, I can't read Chinese.
Mhm. This is my city.
Oh, okay. Can you give a larger view? A larger view
Yeah,
farther
yes.
away so I can see
Yes.
perspective of where exactly in
This is
China.
our city.
Yeah, make the screen smaller.
Uh-huh. This
Can I have
is
a larger
my,
view, like the press the minus
okay,
to make larger.
larger. Let me show you my hospital.
Oh, okay. Big city,
Big, very big.
1 million,
4 million.
4 million.
Uh-huh.
That's a small city.
4 million.
That's smaller
This
than
is
Cuenca.
this is my hospital.
Okay, I can see you.
Yeah, this is my hospital.
Okay.
Yes.
Very good.
Yes.
Very good.
Okay.
Thank you.
Okay.
Thank you. Let's try
Thank you.
Joffrey. Joffrey, can you show us where you're from?
I'm from Ecuador, in Cuenca, Ecuador.
Oh, can you do it? Is that possible?
Yes.
Can you do it? If you can't do it, that's okay. I think he's getting hold. I think he's doing it. You there, Joffrey?
Yeah, yes.
Oh, you're just trying to share, huh?
How are you?
Okay. Can you screen share it all? There you go. There you go. Oh, you're doing it from your smartphone.
Yes.
That's good. Very good. You're learning, huh? Wow, that's good.
Oh.
This is from a smartphone.
This
is from a smartphone, Young Hong.
Use my computer.
Okay, is that Young Hong? Excuse me, Joffrey. You're from Ecuador, correct?
Yes.
Yeah. Okay. So.
You are seeing?
Yeah. Cuenca, Ecuador.
This is Ecuador.
Very good.
Cuenca is a small city.
Small city. It's north of Quito, right?
Quito is 80,000
Cuenca, Ecuador. Okay, yeah, everyone can see where it's at, right? You see where Quito is? It's in northern Ecuador.
It's another.
It's in mountain. It's a very beautiful city, right? It's considered to be a retirement center.
This is Quito. Yes. Quito is near to Colombia.
And that's where one of the fountains of youth is, right?
Yes.
Quito.
I gotta get there. I want to see these new developments in computers. Okay, very good, Joffrey.
Thank you.
Thank you. And we got one more. Naru, can you show us where you are in Morocco? You want to show us, Naru, where you're at? Can you do that on your smartphone? It's not easy. That's okay if you don't know how. Don't worry about it. It takes a little while to get to know the smartphone. I don't know it that well, but just like Joffrey did, you can screen share. It's at the very bottom. It says share. Click on that button. There you go. You got it. You got it. There you go. Okay, the screen is yours. Okay, there you go. Look at that. Robot. You know, most people know Morocco. You know how, Nuru, they know Morocco? Nuru, can you hear me? We're not getting your audio. Can anybody hear his audio? Or is it my audio? Can anybody hear me?
Yes, I can hear you.
Yes.
Oh, okay.
Yeah, you can hear me now?
Yeah, I can hear you now.
Okay, now we
Okay.
hear.
Okay, it is good. So you see this
I can see your smartphone's working hard
yeah.
to get that screen up there.
So you see this, it is
It's on the coast. Rabat is it on the coast, Rabat, of Morocco?
yes. You see?
Okay, we see
Yeah.
part of it. We don't see the whole
Yes.
map. Is there any way you can make it bigger? The map.
Ah, wait, let me
The
show.
map is pretty small there.
Yes, you're right. Let me show you. Wait. How can I do that? All right.
It could be we're overloading the smartphone, and
Yes.
it just can't put the screen up. You know, it's asking for a lot of bandwidth, and you just don't have it. That's okay, Nero. That's okay. It's just it looks.
Is that okay?
No, we can't see it yet. I think it's working too hard. It can't do it.
Ah,
You see how hard it's working? It just can't set it up. Well, thanks anyways. Okay. Well, thanks everybody. Oh, it's getting better. What happened there?
okay. No problem.
Okay, I guess we'll have to postpone it to another time when you're at a stronger internet connection.
Hello, Mr. Marco Meloni. I hope you enjoy the article that I sent you last time.
Yeah, absolutely. Thank you very, very much. Very,
Okay.
very interesting. Thanks. You're being very, very kind.
And
Okay.
we have a late arrival here. We'll just introduce him. Remy Kleb. Kleb, can you missed the lecture, but I'll send you the video. Could you please introduce yourself?
Myself, I am Dr. Kleb. I am a neurosurgeon from Mauritania.
Ah, okay.
I'm sorry, did you hear where he's from?
Okay, that's a club endoscopy neurosurgeon.
Okay, you guys know each other.
I know him. I know him.
Where is he from? Mauritius?
Mauritania.
Oh, excellent. In Africa,
I
right?
am.
In Africa, right? Wow.
I am in France. Yeah.
I think.
Welcome, Remy. I have your email, right?
Yeah. I have it.
Okay, so you get all our notices. That's great.
Hello, Mr. Remy Kleib.
Yeah. Okay. Okay. Let me just announce here. We have a talk tomorrow with Ibcharian, and let me just put it up here so you guys can see it.
Ah, okay.
Yeah. I'm sorry, Sunday. But IPE is talking about
Okay.
clinoidectomy, intradural and extradural. at 5
Oh,
5 p.m.
great.
5 p.m.
5 p.m.
Oh, I'm sorry. 5 p.m.
Sunday.
Yeah, Sunday.
Okay, it is good.
Oh, this is a
So
way to
what-
this is a way to give a presentation. 5 p.m. Sunday, and I think in Morocco it's 1:30. I think.
Ah, it is good. So what about I want to know what will be the next topic, Ulrich? Do you want me to prepare something, or you have one part to done?
Yeah, yeah. We were thinking about doing meninges for next week. So if you have anything, then
Meninges.
Yes.
Well, we could have 2 talks if you want.
Okay.
You know, if you
Okay.
want.
If you want, you can send me that. I will prepare this topic for Friday.
Oh,
For
that
next
would be
Friday.
amazing. Yeah, that would be amazing.
We could have 2 talks. You know, we could have your regular talk plus Nauru if you want.
Yes.
Yeah, that would be great.
That's
Yes.
great.
That would be good. Okay, gentlemen,
Okay.
I'm gonna stop recording this, and then we can stick around and network. Hold on. Thanks everyone for coming, and this will all be. Let me get my. I got to learn producing here. I got to get my own picture up here. Where is it here? Well, I'm there. There. Okay, I got to pin my video because I want you to see this beautiful background. Neurosurgical TV. Thanks everyone for coming, and we'll see you next week. I'm going to stop recording right now. Thank you.
Thank you.
John. Thanks.